Okay, everyone, it is Pamela, and welcome to our call this week. We are going to be in touch much more frequently as we're going through this pandemic because I want people to feel supported. It is so important that our healthcare workers are supported during this crisis. Today is Sunday, the 29th, and the topic today is telemedicine. I want us to all group source and share some of the tips and tricks that we have, because I know many of us in our ideal clinics are already practicing telemedicine or have migrated into telepsych, telehealth, and are using all sorts of online platforms with success. And there are many healthcare workers out there who are wondering, how do they fit in this pandemic? They don't know how to run they don't know how to intubate anyone or run an ICU, but they still want to connect with patients, and they want to help, and they want to contribute. And there are ways that I think every single person can plug into this through online platforms right now that are being utilized at a greater and greater pace as we're being socially distanced from each other. So, as you all know, I run a suicide helpline for medical students and physicians, and I'm getting a lot more calls, a lot more people with high anxiety wondering, are their practices going to survive this? What are they going to do with the decreased revenue that they might be experiencing in a few months if they're dealing with insurance companies, or how do they migrate and actually start collecting cash payments from credit card online, using online services? So there is just, are they going to, people are obviously scared about infecting others and being, in the ICU themselves, or losing a coworker who gets infected with COVID. So there is a lot of opportunity amid the despair for innovation. And I think many of you on this call are leaders in innovating, and I look forward to hearing your thoughts as we share some of our best practices that we've come up with to reach our patients in this critical time in our ideal clinics. So a little bit more that I want to share is the fact that I'm hearing not only from doctors who are distressed in the hospital in the outpatient settings, but also from medical students who are wondering, well, what should I do? All my classes have been canceled. I'm sitting here at home. They might, we might graduate early. They're going to throw us into these hospital situations where I'm not sure if I'm going to be able to handle this, or there's IMGs who haven't matched to residency, who've been applying for years, and they want to contribute. There's so many people that I think have pent-up anxiety and fears and frustrations about not being able to contribute or being able to reach people in a way where they can help in this crisis. So I want to just preface this by saying I think everyone can use these platforms no matter where you are. Whether you have a medical degree or not, there is a way that you can reach people, you can triage, you can answer questions, you can do things within the scope of your practice to help others. So I want everyone to leave this call with a sense of hope and inspiration that even though some of you are lonely, or some of you may have had passive suicidal thoughts who are listening to this, or have fears of contracting this virus, there is hope, and we are here for you, and you are not alone. Now, just to give a little bit of information about who I am. So I have been in practice 15 years in my ideal clinic. Next week will be my 15-year anniversary. I'm so excited. It's been quite a wild ride. Again, this was a clinic that was designed by my patients in the community of Eugene, Oregon, who contributed testimony during a series of town hall meetings where I asked the community, what do they want? Because I was feeling, like many of you may be feeling now, that our leadership at the highest levels and even within medicine is not that responsive to the true needs on the front line. And so I wanted to know how I could serve my patients, and I didn't just want to hold them hostage to something that was passed down to me as some sort of tradition, right? I didn't want them to be, pent up in a big box clinic and in a cubicle with me any more than I wanted to be in a cubicle. So what I learned from these town hall meetings, which was so awesome, and I do want to share for some of you who are just launching your practices and feeling like, oh gosh, what bad timing, I just launched my practice and now there's a pandemic. I want to take you back 15 years ago, and I'll share more about this in a future call, is 4 months into launching my ideal clinic that was designed completely by my community, Katrina happened, and I ended up in the Astrodome, like volunteering during this another national crisis. And so I want you to know that these are opportunities to show your best, to come up and demonstrate how you can help. And I think all of us have a way that we could be helping others heal, whether it's in our neighborhoods, in our practices, in hospitals. There is a place for everyone. And so I want to share why I believe I've been able to be successful for 15 years in my practice. Number one, it was designed by the community, so I'm not sort of just putting a shingle out there and hoping to capture people with what I think is so great. Like, this was actually designed by the end user. Whenever you have the end user involved in designing the system that works for them, it's going to work the best, okay? So I'm a real fan, as you probably know, of breaking through hierarchy, really getting at eye level, heart level, soul level with the end user, seeing what they need and delivering it quickly. Like, I'm not somebody that just sits in a theoretical realm, shooting off ideas. Like, I have an idea and I put it in action, usually in a pretty quickly. And that's another benefit of having your own clinic, is that you could have an idea that you want to do something during a pandemic, and you don't have to sit in a committee meeting and ask anyone. You don't have to get permission. I want to, again, tell you all that I believe that you are smart enough, intelligent enough, resourceful enough, creative enough to come up with innovative solutions, no matter where you are in your medical training or nursing training, to actually deliver your gifts to the world during this pandemic. So do not feel like, for some reason, there's a lot of guilt that physicians have been expressing to me on these private calls, and even during our Zoom call last week, that people feel like, I'm not contributing, I'm not in an ICU, I'm not using my skills, I feel a little guilty. And it's like, I don't want anyone to feel guilty. There is a place where you can plug into this, and tonight's theme is going to be doing this through online portals, through even actually using the old-fashioned telephone. Can you believe that still you can use a landline and reach people the old-fashioned way? So since helping hundreds of doctors launch their independent practices, and other healers and acupuncturists, and, I want to just say the key to doing this is simplicity. I am like the queen of simplicity, cutting through all the minutia, all the extraneous material that's irrelevant, and making things happen. So get your thinking caps on here, get excited, and I'm going to just launch through a little bit of content on how I use telemedicine in my practice. Then I'm going to open this up to two other lovely people in our group. One is a psychiatrist who's practicing telepsychiatry with great success. Another is a nurse practitioner, just opened her amazing community wellness center, and she's going to be sharing how she uses telehealth in her practice. And the benefit of having both these people speak is they're coming from different angles. One's a psychiatrist, I'm a family doc, and then we have a family nurse practitioner. We also have people that are taking insurance or not taking insurance. Like our psychiatrist is not taking insurance. I am out of network with insurance, but I'm totally comfortable billing insurance. And Carrie is going to share how she, is up to date with all the codes and everything that you need to use for telehealth if you're still taking insurance reimbursement. So we're going to get like the full scope. And there's even ways, by the way, that RNs can participate in telehealth. So I want everyone to feel part of this. I'm speaking to you, and I'm going to start in with some of the essentials for a successful telemedicine, telehealth, telepsychiatry practice. Number one, I really think, is low overhead. If this is not the time to have low overhead, I don't know when is, because our world has gotten very small, much smaller during the pandemic. We are sitting neck and neck with the person we promised till death do us part, and hopefully our marriages are going to make it, because I'm hearing from people that are like, they're telling me I don't like who I'm quarantined with. Yes, Teddy has shared with us that many people in China, I think after the actual pandemic started, the curve started flattening out, the line for the divorce court started ramping up, because like being locked in with people, trying to get along, trying to still live your life, trying to have your business stay afloat, and homeschool your children, can be quite the trauma. And we did have, content last week on how to deal with pandemic trauma, and that's freely available also on the website for anyone who's suffering more with the trauma piece. Please reach out. We have even more resources for you on that. But essentially, back to the telemedicine, I have been using telemedicine in my practice for 15 years. Some of you don't know that. Maybe I'm one of the first people to use telemedicine. Who knows? It's because I have a very unique way of doing it, which I will share. I don't have any special platform. I started out offering it for free, 15 years ago, and now I do have a fee schedule that is the same whether I'm using it for telemedicine, house calls, office visits, or whatever. Of course, right now I'm on day, I think, 11 or 14 of my quarantine after leaving New York City, so I'm not doing house calls or office visits at the moment. I'm purely doing telemedicine. So back to the first point that I made earlier, low overhead is key. I think many of you who are in small square footage offices are really happy that you didn't rent a larger space because you can't really use it very much now, right? There is the beauty of being able to deliver medical care through micro practices, micro spaces. Many of you are practicing from your home, which is really, really awesome. And you can write off part of your taxes for your house payment, all sorts of benefits of having a home business office. Start to think creatively on how you can lower your overhead during this time and deliver to your patients exactly what they need and quickly through online resources. So as many of you know, I launched my physical practice for $627 when I first launched back in 2005. And if you've not seen the video on how I did that, you can Google the keynote that I did in Las Vegas. I think if you just Google how I launched my clinic for $627, you will land there. There's a 1-hour video that's really fun. And also a great sort of slide deck of step-by-step how I approached this. And I'm also sharing other people who've launched their clinics cheaper than me, for $85. I know somebody that started on day one with her practice. Okay? Now, all I had on day one before I saw my first patient was 2 Goodwill chairs, which cost about $40. I had my tiny little office, which my rent for that was $280 a month. Plus, I paid my quarterly malpractice premium, which was $307.50. Now, altogether, that's basically $627. If I were to do this again today and just launch my practice using telemedicine, I could do it for that $307 because, I'm not somebody that's going bare. I am covering myself with medical liability policy. They're very cheap, by the way. I want people to understand. If you're concerned about how much you would spend for medical liability, please Google the article, How I Saved 86% on My Malpractice Premium. I can help people do that. I just think don't let anything stop you. Malpractice insurance is not expensive, okay? And you can pay it quarterly, and the first year it's going to be really cheap, okay? Then, to launch your ideal clinic, of course, you need all the usual elements we've discussed for years, which is knowing your target demographic, having sort of a specialty niche. I think many of us, now that we're sort of homebound and running our practices from home, we're starting to realize that there are special groups that we want to serve. Maybe we want to do an ADHD support group. Maybe we want to do unique material that we want to deliver online for certain segmented parts of our target population that we serve. This is a great opportunity to put together those PDFs, those videos, those, maybe the ebook that you've long wanted to write, on thyroid. This is a great time to do that. But again, really important to use low overhead concepts because that way you're not sitting there, and some people are sitting on, high bank loans and mortgages for buildings. I know many of you are thinking of just giving up your physical office space and going 100% with telemedicine for a while or, indefinitely. So this is a great time, again, to experiment. I think avoiding staff when you're starting is really smart because you can obviously do this in a very small square foot, footprint. You don't necessarily need a lot of staff when you're starting out with anything. We're going to give you so many free resources that you can use to just get going. You don't need even IT help. These platforms that we're going to share are very simple. And so there you go on that. so for telemedicine, you do need a platform, okay? When I was thinking about the content for this call, just to keep it super easy, really the only thing you need once you have your ideal clinic open is like a platform and a payment model. I mean, if you really break it down, that's all you really need to practice telemedicine or telehealth. And so for the platform, I've chosen the absolute easiest, simplest platform that you could possibly ever choose. It is free for everyone. Everyone already has this thing going for them to even make it on this call, which is you have a telephone, okay? And telemedicine in its original form, in my mind at least, was something that we could practice with the telephone. You've probably seen that cute picture I posted earlier of me in a treehouse. It's like, okay, I actually can practice treehouse telemedicine. I just posted that on our chat. And meaning, as long as you have your cell phone and you have coverage, you know, you can be providing medical care and billing for it. And that is exactly what I'm doing just with the old-fashioned telephone. Now, if you want to use other platforms, you can, and by the way, people who are, you know, older people, maybe, you know, geriatrics patients are not generally on all these, you know, they're not often, you know, hooked up on all the social media platforms. So I think like using the telephone and knowing that you have that as a backup or your primary way of connecting with people is fine. So the reason why I was using this is because I had patients early on who would move out of town and couldn't find a new doctor, so I continued to take care of them through telemedicine visits until they were able to establish 6 months down the road with a new doctor. Obviously, that's easier for psych stuff out of town because I was not able to do, you know, exams on them. When I'm out of town, because I was living part-time in New York, of course, like I can reach my patients in Oregon, no problem, and, you know, having lab visits, you know, telemedicine consults talking about their Coumadin, you know, their levels, PT-INR, all that stuff can be done easily through telemedicine. Also, we're all learning during a pandemic. It's pretty essential. A few other things I want to share before I turn this over to Kendra, who will go first, is that, you know, there are a lot of other platforms I'm sure she will share with us, as will Carrie and others. You know, DoxyMe is one that's really popular. It's free. It's HIPAA compliant. There's UpDocs has a paid version, Spruce. There's so many. You can just ask other physicians out there. There's a lot of different platforms. So you just find one that's easy, that's maybe free. If you want to start with something, think about what your needs are as a clinician, right? Do you need audio only? Okay, if you're doing telepsych or, you know, talking about a lab result for PT and INR, you know, there's no reason why delivering, you know, labs to somebody would necessarily need to see their face, you know, so it's very convenient for me, and I'm much more, I just love the audio for some reason. I feel like sometimes seeing things distracts me from what I'm hearing. I guess I'm just much more of an audio learner. And so also it's easy to multitask when you're doing audio type calls because you're not having to sit in one place. And I'm not somebody that likes to sit in a chair for an hour staring at the same thing. I have trouble doing that, so I need to move around. And so just think about, would audio serve you? Because if audio would serve you, it's totally HIPAA compliant. Use a telephone, okay? A landline, a cell phone, whatever. You could be using that now. Okay. Now, if you need audio and video, that's when you start thinking about, you know, DoxyMe, these Spruce, other types of applications out there. And then obviously if you need an exam, you're going to have to meet the person somewhere. You know, now the beauty of this, even during a pandemic, is you could decrease your exposure by doing the whole history online ahead of time and collecting as much information as possible so that when you finally see the patient, maybe you just swab them in their car and let them go. Or you do the limited exam however you need to, and then, you know, it still decreases and keeps us socially distanced, decreases your risk of acquiring this infection. So you also want to find out what your patient's preference is. But the main thing is, I think what it all comes down to is you need to end up enjoying whatever process you pick. It's kind of like exercising. You could try to force yourself to do. I just had a really beautiful bike ride, by the way. It's so nice. When you pick an exercise that you're going to enjoy doing, right? So pick the method, the platform that's going to be enjoyable and not break the bank. And then the last thing I want to say before I sort of turn this over to Kendra. Oh my gosh, I have a few more things. So the payment model, obviously, if you're taking cash or check, this is what I've been taking for 15 years, people are still paying the same way. They can pay online using Square. There's all sorts of, methods to collect money from people. If you're doing insurance reimbursement, it's a little bit more complicated because then you have, special codes, which Carrie will talk about, that you will need to use on your billing. And some people are nervous about whether insurance companies are really going to reimburse right now during this pandemic. And I think you just have to look at your contract and contact your what do they call them? The local provider rep. The provider rep for your insurance company, and make sure that in this pandemic that you're going to get reimbursement before you start submitting a bunch of codes that they end up potentially not covering. So one thing is that the Center for Medicare and Medicaid Services, of course, is waiving restrictions on the use of telehealth during the duration of the COVID-19 public health emergency, but again, you need to check with your individual insurance carriers. I think if you're taking cash payments, it's not so much of an issue. And this is just a little note that I got today from one of you. I've done half dozen encounters this week using my iPhone and FaceTime. The hours I spent with some poor computer software to do this, only to realize that all my complicated geriatric patients would have to install the same BS software to play made me angry. So I said, F it, and FaceTime them. Went well so far, but there has to be a better way. DHHS is relaxing the guidelines to allow those visits to be billed at standard 99212 to 99214 visits currently, but expect more BS to follow under the current admin. Okay. So I hear the frustration. We're going to answer as many questions as we can today. I will collect the questions, and we will answer them at the end so you can add them to the chat as we're going. But I think what I'm going to do now is just turn it over to our first lovely guest today, which is Kendra. Let me first unmute her as soon as I find her here. All right. So,
hello,
Kendra, welcome. You're here.
Yay! For the first time in like forever.
Sorry for the long intro, but I had a lot to say, and for some people that aren't familiar with our group, I just wanted them to catch up with how easy it is to really have your dream clinic, and people just stay in fear a lot, as you know. And Kendra is a psychiatrist. She will take it from here. I'm sure you're hearing a lot of fear from your patients and others.
Yeah, absolutely. And so I just wanted to say, too, I have some content that I'm going to discuss, but then obviously definitely wanted to answer questions, like specific questions that you guys have, because I'm sure you guys have a lot of them. So I think a lot of you guys know me, but for those of you who do not, my name is Kendra. I'm a psychiatrist. I currently live in Virginia. I have a nonprofit organization called Free Range Psychiatry. I focus on holistic psychiatry. And when I started, when I opened up actually a little over 2 years ago, my initial dream was actually to do only telemedicine or telepsychiatry and house calls. But I ended up giving in and thinking, you know what, I have to have an office. Like, what am I thinking? That's crazy. So I had an office for a little bit, and the funny thing is it didn't work out. The office actually totally didn't work out. So then I moved to a home office, and then I went on maternity leave back in November of last year, and back in November I made the decision actually to completely even stop doing the home visits completely and just do 100% basically telemedicine. And so I literally have, what is today's March 29th? My official day back from maternity leave is April 1st. So I had already planned to be doing 100% telepsychiatry. So it's crazy because my plans, I'm super, super lucky because my plans basically are not changing because I get to do what I was planning on doing back in November, which is kind of crazy. So just a little bit of background about kind of my experience with telemedicine. I previously lived in New York. I worked in an emergency room for about 3 years, and they actually did use telemedicine. So I was in one emergency room in Manhattan, but I saw patients at like 3 or 4 different affiliated hospitals. So basically doing like emergency psychiatric evaluations. And that's where I kind of fell in love with telepsychiatry and just thought it was so much fun and so cool. And that's kind of partly, what gave me the idea when I started this free-range psychiatry to have a big component of it be telepsychiatry. Let's see. So yeah, just some things I just briefly wanted to talk about. Some Pamela kind of already touched on some of these things, but just quickly, some advantages that you probably already know of doing telemedicine. Low overhead, like Pamela said. I just want to say something, which is that I believe I was just trying to calculate. I think my overhead is about like 2 or 3%. I actually just said 2 or 3%. Like, it's that low. It's crazy. Especially now that I'm doing, that I work 100% from home. My overhead is ridiculously low. And the huge benefit for me is that I have a 1-year-old and a 3-month-old right now. So I see my time as being very precious, and I don't like to, do anything more than I need to. So being able to have this uber low overhead model is like the best thing in the universe for me because, it allows me to spend more time with my family, which is awesome. Other advantages, like actually someone asked me this one time where they were like, well, if you're doing this telemedicine, like that probably means that like all your appointments run late and, you're probably using more time doing the technical stuff. No, my appointments actually run, my telemedicine appointments I found or more on time than my in-person visits, actually, because it's a lot easier to just, you start it and then you do it and then you stop it. So I find that to be kind of an advantage. Obviously, because of the current pandemic, there's an obvious benefit for doing telemedicine, just that, you're safe from catching anything from your patients. One of my personal favorites, again, as a mom of 2 young kids, is like working without wearing pants, or at least without wearing anything, any clean clothes or anything like that. Like I love the just being able to just kind of like wake up and just go to this room in my house and see my patients and do everything I need to do. For me, that's a huge advantage. And just being able to see my kids and care for them. Yeah, for me, these are all huge advantages. The disadvantages or challenges I would say for telemedicine are, the biggest one is, as a psychiatrist, I can do a mental status exam basically without, touching my patients. Obviously, for other folks, not being able to do the physical exam, that makes it a little bit more challenging, although there's, various ways around that, as Emily was discussing. And then another challenge that I have seen is just that although I absolutely love working from my home and I would not do it any other way, it can get a little crazy sometimes when I have, screaming babies and barking dogs and just like madness, like not having that kind of separate space, which is interesting because I'm realizing that like the whole world right now is starting to like experience my reality. Like my reality has been like, living in my house and doing everything from home and doing everything virtually. Like, this has been my reality for like years, but now it's like the whole world is kind of experiencing that. But anyway, that is one of the challenges. So Pamela already kind of touched on, I was going to talk a little bit about like kind of what you need to get started. As Pamela said, yes, the very bare minimum you could use is your phone. As far as other options, Pamela mentioned some. There's a ton of options out there. One thing I think as someone mentioned on the chat is that currently HIPAA has basically been suspended. So you can use FaceTime, which otherwise is not HIPAA compliant. You can use anything. Right now, they basically said anything at all that you'd like to use that works is okay to use. Probably one of the more popular ones is Doxy.me. There is a free version and it's HIPAA compliant. It is what I used up until recently. One of the reasons I switched is that I realized that it was getting a little bit overwhelmed. And so I was having like problems connecting and things like that, which I think is just all because of what's going on with the pandemic. It's just they didn't plan to have these many people kind of using it. I actually am using Zoom now, which I'm pretty happy with. I think it's probably one of the best ones. It's cheap, except for the fact that if you want the HIPAA compliant version, you have to pay more. But my plan is to just keep using this version until whenever is kind of my plan. But yeah, there's a lot of other options out there. As far as like taking payment, Pamela kind of already touched on this. The two biggies are Square and Stripe for taking credit card payments. I happen to like Square mostly because it integrates with like everything. It just happens to be a very, very popular method. And because of that, it integrates with like almost every EHR. It integrates with like just all different kinds of things. It's got a nice app. It's just very, very super, super, super user friendly actually. But there are tons of other kinds of options out there. So some things that I just wanted to talk about too are because of obviously what's been going on. There have been a lot of changes to laws and regulations affecting telemedicine. So the first one I already mentioned, which is that basically HIPAA has been basically kind of suspended so that, you can use any kind of method that you want to communicate with patients. Another biggie, this was definitely really relevant to psychiatrists, but probably other folks as well, is something called the Ryan Hate Act. So I won't go into the details, but basically, long story short, years ago, there were pill mills going on where you could just fill out an application online and you could get like a huge box of oxycodone shipped to you. And then someone died, and then they cracked down and said, okay, we can't have this. But when they wrote the law, which is called the Ryan Hate Act, they didn't really write it very clearly. So what they ended up basically saying is that if you want to prescribe a controlled substance to a patient, technically you are required to have at least one initial in-person visit before that happens. And so that really, really limited telemedicine in many ways because lots of doctors couldn't, if you didn't have a brick and mortar place, if you're like me where, I don't ever see my patient in person, then you wouldn't be able to prescribe those substances. So that's also been suspended. I have a feeling that it's going to be suspended and then it's going to be changing and lots of other stuff is going to happen. But for the time being, that's also been suspended. Another big thing that I'm sure a lot of you guys are aware of are just basically the policy of health insurance, basically telemedicine parity. So prior to this pandemic, it really varied state to state. So in other words, by parity, I mean health insurance companies reimbursing telemedicine appointments at the exact same rate as they would for an in-person visit. So that varied based on the state. I'm up to, I think, 5 state licenses now, and several of the states that I practice in have parity and several of them did not. But now basically the federal ruling is that like everybody has to be, Medicare has to be, Medicaid should be, and all private insurances should reimburse the same. Now, where the anxiety comes in is that, yes, they said that, but does that make it so? And the reality is, no, it may not. And actually, they've been trying to enforce parity for years, and still there's a lot of health insurance companies that aren't doing it. So I'll say that, they should be doing this. Is it going to be perfect, and is everything going to go 100%? Probably not. But I do think it's a really big deal. And I think that even after the pandemic is kind of over, it's going to have lasting effects. Meaning that I think that telemedicine now is it's become so popular and that I think all of these laws are going to be changing. So another thing, sorry, I'm thirsty. Another thing just I wanted to touch on is for folks who have thought about seeing patients maybe not in the state that they're in. So prior to this pandemic, basically the rule that we were all supposed to follow is that you have to be licensed, you have to have a medical license in the state where the patient is basically physically standing when you're doing the telemedicine visit. So, if you are in Oklahoma, but your patient is in Pennsylvania, you have to have a Pennsylvania state medical license. Because of what's been happening, many states, and there's lists of them that you can find online, have been changing and loosening their requirements. Some of them saying like, okay, well, maybe you don't really need to have a regular medicine, regular license, but you can do a telemedicine only license. Or some of them are saying, well, if you're coming into the state, to help and it's an emergency, like then maybe you don't really need to go by, all the state licensing, things that you have to do, et cetera, et cetera. It really varies based on state. But things are changing literally, like I'm going on to this website and checking every day, and like a new state has something new like every day. Like it's changing that quickly. So basically, I think that where we're going is that, like, I think this is kind of the telemedicine. It's always been a frustration of mine, right? Is this whole state-based idea, right? It's very limiting to telemedicine in general. So I think one thing that's good about all the craziness that's happening is that I think that we're going to kind of maybe hopefully move away from the state-based licensing, which would be pretty awesome, so that you can just have a medical license and you can see anybody anywhere, via telemedicine. I think those were the things that I wanted to just kind of cover. Pamela, would you like for me to talk more, or what would work for everybody? Could I haven't looked at the questions. Do you want me to just maybe start answering some questions, or?
I'll ask the questions that people have asked, sort of, de-identifying them, so that it's all sort of anonymous. But I know you probably need to get off the phone sooner than others because you have child care issues and have all your bouncing babies, and we're so happy for you and love looking at all these pictures. But one question that came up was, which website are you checking now for these license limit changes? When you said, I check the website every day. And
good question. So there's a lot of websites. My favorite one is actually through PRMS. That actually happens to be my malpractice carrier. And the reason that I even found this link, I'm trying to see if I can find it right now.
How do you spell it? Exactly.
PRM, P as in Peter, R as in Roger, M as in Mother, S as in Sam.
Okay.
They happen to be that happens to be my malpractice carrier, and actually I was specifically asking them, and then they said, hey, we made this really awesome site, and it's just like a sorry, I don't want to find it right now because it'll probably take me time, but I can find it and I can share it here, and I can share it on the Facebook page and everything. Okay. But they basically put together every state, and they've been updating it every day.
Awesome. Okay, so that was one question that was directed towards you specifically. There are some other questions like, are you getting people to pay before or after their televisit?
Excellent question. So I learned very quickly that it is, or at least I feel, very important to actually collect in advance. So my policy has changed multiple times since I started. My current policy is that I actually, the system that I use for my EHR, which happens to be IntakeQ, is so awesome that I don't even do anything. I have the patient on my calendar, and that morning, early in the morning, all of the payments for all of my patients' appointments go through automatically. They're automatically charged. But yeah, my policy has basically been, but before I had it done automatically, was always to charge in advance, and plenty advance, so that what I find happens sometimes is that, someone's credit card may expire or they lose it or whatever, and so it may not work, and then they don't find out till after the appointment. So what I do is my policy is to always charge in advance, and if there is some problem, then to sort it out before the appointment.
And I totally agree with that. Like for telemedicine visits, especially with people who are established with me that are used to sort of just paying the check thing, and they're prepaying for multiple visits at once, and that's awesome because I know there are a few people that are not into paying the 3% credit card fee thing. But I definitely recommend, if you're doing telehealth, especially if it's a new patient visit, to get prepayment. So I think that is very smart.
Yeah.
So
definitely with new patients, 100%.
Yeah, with new patients, yeah. So maybe we'll let Carrie speak for a little while, and then I'll ask some of the more generic questions that could be fielded by either one of you. And if you have to go, we totally understand, and we will figure out the answers. Just continue the conversation online. So yeah, I'm gonna. Unless do you have anything in closing you want to say for people who are like holding back, afraid, scared? Any last little bit of wisdom, and then we'll move on to Carrie.
Yeah, I guess I kind of just want to echo what you said, which is that like now is the time. Like this is all this craziness that's going on, like it's just insane. But this, some good can come out of this. So like this is an opportunity, I think, for folks, and this is an opportunity to be a part of like this huge like healthcare movement. And it really, 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 really is not that hard. I promise you that like once you just pick a platform and you pick this and you set it up. I find it to be way easier than trying to figure out like how to do like the in-person visits. Like it's actually like super simple when you get the hang of it, and it's so much fun. Like in the 2 years that I've been doing this, like I have seen patients in their bathroom, in their cars, at a grocery store, at a cafe, like in their college, whatever, like in their bedrooms, like in a million different places, in different like countries. Like it's just really, really cool. And my patients, they love it. It's so nice that, for example, too, like when they're sick, like if they're sick, like they can still see me. If they, they can't, if they had car problems, they can still see me, like, and they can do it in at their convenience. And I just think it's like an awesome, awesome thing to be able to offer. So yeah, that's my 2 cents.
That's awesome. Thank you so much. We are very inspired by you. And I'm going to switch over to Carrie right now. I'm going to unmute her. And all right. So, Carrie, are you here?
Yes, I am.
Awesome. Sorry that took a while to get to you, but we saved the best for last. So, yeah.
100%. Hey, y'all. I was just gonna introduce myself for anyone that doesn't know me. So, my name's Carrie Trogett. I'm a family nurse practitioner. And in the state of Washington, we have autonomy, so I can open my own clinic, which I've done, and it's a family practice clinic, but I'm actually trying to specialize in obesity. So I have a certification that specializes in obesity through the AAMP, and I'm looking at getting certified with the Obesity Medicine Association. So basically anyone that has a BMI over 27 with one or more risk factor, or a BMI over 30 going up to 35 to 40, depending on the patient, they would be like my ideal patient to help take care of. So I utilize telehealth for that, but my last job was one of the first primary care providers to actually do telehealth in my region. So I have kind of a strong background in it, and I'm really passionate about where healthcare and technology intersect. So it's kind of a fun topic for me. So that's kind of my background. I'm going to kind of talk about a few things. The first thing I'm going to talk about is going to be coding basics, and then the last thing I kind of wanted to touch on, depending on time, is going to be kind of leveraging your staff to help you utilize how to get access to your patients. So the first thing that I just wanted to kind of talk about was basically what to kind of think about when you're doing with your telehealth video visits. And I wanted to just touch on the fact of some of the things that I've heard of. There is pay parity in a lot of states on the West Coast. Like I'm in Washington, and I know Oregon has a pay parity law as well. But I wanted to bring up the fact that if you're looking to use insurance, I know that Blue Cross Blue Shield has had some argumentation with using and reimbursing telehealth because they've contracted with TeleDoc, which is another online platform, and they're actually not reimbursing their primary care doctors. They're just saying, well, they have to use this, and patients have to pay extra for this telehealth benefits, which I don't really understand why that's needed because patients are paying higher premiums. We're getting reimbursed less, and it doesn't cost any more to reimburse for a telehealth visit. So I think that's something important for us to recognize and mention to our patients, that they should be asking, why do I need to pay extra for a telehealth benefit? So just kind of know that even if you have a state that has a really high level of reimbursement and some really strong telehealth laws, that insurance companies are finding ways around that. So I just wanted to make sure that you know that your patients know that. And just it's frustrating to me. I think it's immoral and unethical to delete the primary care provider from the entire situation, especially when population health is so important right now. So the other thing that I was going to talk about is just like your remote monitoring setup. So what are the two kinds of visits? I actually have a video that I recorded that kind of goes through like the 4 things that you need, and then also like the coding. So I'm going to kind of breeze through it, but just know that the numbers are on my website, and I'm going to post that afterwards. So basically, the things that I kind of wanted you to know about is that there's 2 types of telehealth that I kind of consider things dropping into this. So the first one is going to be your basic telehealth visit, and that's what you guys are kind of talking about right now, which is I talk to the patient either via telephone or video visit, and then I may either prescribe meds or I may just counsel them. And then the other visit is going to be your store and forward visit. So that's like through a patient portal, a patient messages me about COVID, and then maybe my nurse calls them back, or I don't even call them back, but I talk to them via the patient portal. And that is actually a whole separate charge code that you can charge insurance companies. A lot of providers don't know that exists, but you should be getting paid for that time because you're using your medical degree or your staff to use that. So the first one I wanted to touch on here is going to be the video visit. So for that, in 2019, CMS actually deleted the need for the GT modifier, but a lot of insurance companies still utilize the GT modifier. And I think it's a great way to track whether or not you're actually using telehealth in your clinic. So using that GT modifier, and some commercial insurance companies actually want you to use the 95 modifier. So it's just really about what you know that the insurance company uses. And if you don't know that they use one or the other modifier, I would actually just put both of them on there. And remember that you're changing your place of service from an 11 to a 2. So that was a big change. They deleted the GT, but then changed the place of service to a 2 instead of 11. So if you do your super bills, you kind of know what I'm talking about. The next thing that I was going to talk to you about was the store and forward, because a lot of people have some questions about that. And there's kind of 2 things that you want to think about with store and forward. One is, am I doing it or is my staff doing it? Now, remember that if your staff calls a patient and talks to them, CMS actually does not make any mandates on who the person is that's talking to the patient. What they say in their coding definition for this is it needs to be, quote unquote, a qualified healthcare professional. That can be an MA, it could be an LPN, it could be an RN. And so you can see where you can actually leverage your staff to help you with your documentation. So, for example, this would be a patient calls in that is a worried well, extremely concerned that they have COVID symptoms and they want to talk to someone about that, and say the conversation takes a really long time. Maybe it's a half an hour because she's telling you about her traveling, and we all know this type of patient, and they just need lots of reinsurance. So say that your MA gets that information, then comes and talks to you, and then you say, no, I don't think this patient is actually needs to be screened. So then the MA calls back the patient and talks to the patient a little bit more, and that whole entire time takes over half an hour. You can actually charge for that, which is I think it's a 99452. And you don't have to do any documentation. Your MA, who made the phone call, does all the documentation, and then you could just do an addendum to that says, I agree with the plan, and you can charge that visit, which I believe is, that visit I think is around $50 reimbursement, and the 99451, which is less than 5 minutes, or 5 minutes about-ish, is going to be, I think that's about $20. So this is pretty lucrative if you're using it. If you think about the amount of times that you're talking to patients through a portal about anything, then you can see how much money you're actually missing out on that. So there's some other things that you could look at setting up further on, but I don't think I'm going to talk about that today because I've already kind of, I'm at 5 minutes, so I don't want to go over my 10-minute mark. So I think that looking at remote monitoring in the future is something that you could look at to be really helpful in terms of setup and monitoring. But what I really wanted to kind of talk on a little bit more, I think it's going to be really helpful during this time, is leveraging your staff to help you out. One of the main reasons why we use that, and I'm sure you guys have all heard the term patient-centered medical home, which is supposed to be a term that was coined by the CMS to really talk about patients coming to their medical home and being able to see someone at the day of. It has a lot to do with open access, which I know Pamela uses in her clinic. And open access is basically a patient calls the day that they need an appointment, and they can get an appointment. That circulates around being about 30% of your patient, or 30% of your day is actually scheduled, and the rest of it's just open. So those are some high-level concepts that you don't really need. Really what you just need to know is that you can use an LPN or an RN to actually do visits for you. So if you have a protocol, so for example, and I've actually written protocols for RNs to be able to do independent visits and LPNs to do independent visits for like UTIs, cough, colds, diaper rashes, that kind of stuff. So they can actually see the patient, document an entire SOAP note for you, because remember that if it's an established patient and we look at the coding documentation, there's actually nothing required for documentation for a 99211, which is somewhere around $30 to $50 depending on your reimbursement rate. So you can actually have an LPN see a low-level patient that doesn't need a lot, and maybe just, how many patients do you have that call in for a UTI and they just need a UA dip? And then you can make a decision based off of that and send off the culture. So there's some options there for you to look at in terms of allowing your LPN to do the visit for you. I would utilize my RNs in more of a chronic care situation, because RNs have a lot more independent decision making, and a lot of states, they actually have a lot of autonomy in terms of their ability to make decisions with you or with other different protocols that you can use. Some of those protocols are the Ottawa Nursing Association has a really great resource for nursing protocols that goes through, like if you have an asthma patient, that they need to have an asthma action plan, a current PFT, like all of that kind of stuff. They can also use telephone triage resources. There's some books out there that are just really thick books that talk about, basically a nurse would get a call about, say, abdominal pain, and then they would flip to abdominal pain in this book, and they could actually read through these protocols, which are standardized and set throughout the country and are validated and peer-reviewed. And based off of that, they would determine, yes, you need to come in for a visit, no, you need to go to urgent care or emergency department. And remember that RNs are the only ones that can do triage. The LPNs should not be making those decisions. Other things I like to use are Dynamed or Medscape as a great resource to help teach my nurses what evidence-based medicine actually looks like and what we should be looking for. It also has a really robust H&P for them, and it's free, especially, I don't know if anyone else in here has a Washington State license, but through Washington State, our licensure actually gives us free access to Dynamed, which is a fabulous resource. And then the other thing I just wanted to point out is you can always call me if you have any questions about how to do any of these protocols or anything that I'm doing. I know this was a really fast talk. I just kind of wanted to get through stuff and not spend a lot talking about it. And my last piece of advice would be to just go ahead and try this. And remember that, especially I think in primary care or specialty visit, because we have to assess them, but I want to actually challenge you to think about, do you really need to put your hands on them? Is it something that you can actually just look at them? Because remember that just looking at a patient, you can actually get 5 review of systems, because you can get constitutional by looking at them, you can get eyes by looking at them, you can get respiratory rate by looking at them, you can get neurologic and psychological. So that's 5 physical exams, and you're already, if you prescribe a medication, at a 99214. So just remember that it is lucrative and you can use it, and to just know your charting and know that you don't always have to listen to heart and lung sounds. So that's my spiel, and I'll let Pamela take over.
Oh, that's awesome. I'm going to actually keep you, and I'm going to unmute Kendra, and we're going to field some more calls on questions on this, if that's okay. But there was one directed specifically at Carrie that I wanted to share, which is, I may have misunderstood when you explained it, Carrie, but it looks like a 99451 and a 99452 is between 2 medical professionals. So office to office is fine, but not from office to patient, right? I don't know if you get that question.
Yeah, I don't know the exact specific code. I'd have to look at my it's because I have a bunch of different codes in my my fee schedule, so it's in there. And actually, what I'll do is I'll just put my website in the chat so that you guys can go to it. And if you watch my video, it has the codes in there. I really thought it was a 99451.
I'm going to post.
I just can't remember what exactly the code is, but I do know that it is a new code, and it was set up in 2019, so it's over a year now, and it is a qualified healthcare professional. It doesn't have to do with being between professionals. It's anytime a patient sends you a message on a portal and you respond back, it has to have those 2 elements, the patient responding and the provider responding. You can use that code, and it's basically in 5 or 30 minutes.
That is awesome. Way to go, Carrie. Thank you so much. I'm going to give some questions now that people have asked, and I've unmuted Kendra, so welcome back, Kendra.
Can you hear me?
So yeah, can hear you.
Okay.
So what programs do people use to e-prescribe controlled substances? What is least expensive? So maybe just speaking about e-prescribing in general and then e-prescribing controlled substances as it relates to telehealth.
Yeah. So with e-prescribing, a lot of EHRs these days will have that built in. So it may already be built in if you have an EHR, or if you plan on getting one, it's one thing to consider whether or not it's built in. Sometimes it is at the same price, and then sometimes there's an additional fee that you have to pay either for e-prescribing or for prescribing of controlled substances. I used to use Practice Fusion as my EHR. I did it while it was free, and I even used it for a little while when it went up to $99 a month. But I eventually decided, for me personally, it wasn't worth the money. So I switched over to a different EHR. I actually use IntakeQ right now for pretty much everything. The only thing that does not do is prescribing. So for prescribing, I use something called iPrescribe, and it's available that you can download on your phone. If you download it on your phone, it's free. I believe if you wanted to use it on a computer, I think that's when you have to pay money for it. But it's free, and it does controlled substances, and it works. It's the easiest thing. Like, you have to get it set up and, put your DEA information and all that stuff in. But once you have it going, it takes seconds to send a prescription in, and I love it. I think it works really well. But there are other ones out there. Another really popular one is MD Toolbox. That's also just like a standalone. I want to say it's around like $30 a month or something like that for that one. That also works, I believe, on a phone and a computer.
All right. I can speak to this too if you guys
go
want
ahead.
an extra.
So both of you should answer. Yeah.
So for family practice, I actually don't accept patients that need controlled substances unless I'm working with them with like obesity medications, because like phentermine is like a controlled substance, and I actually only will do in PAD because it costs $250 for me to prescribe a year. So I might look into iPrescribe, but I use Charm EHR, and I know that you guys had kind of talked a little bit about your monthly clinic costs, and I just wanted to let you guys know that my monthly clinic cost, if I don't account for malpractice insurance, is $35 a month. Yeah, you heard that right, $35 a month. And then with malpractice insurance, it goes up to $145 a month, and that's breaking down my malpractice insurance through 12 months, but I actually just paid that in one full lump sum.
That is awesome. Oh, my gosh. I love it. I love that you all are sort of beating me out on the low overhead thing. But, yeah, having no physical office space, which I gave mine up in December, as you all know, December 31st. So I got out from underneath a physical office. So now I haven't even recalculated I think I'm using my do-it-yourself EMR that I created on my own, so that's $0. And I don't know, my overhead is pretty much just malpractice premiums, which I think right now, by the way, everyone should be getting sort of a part-time malpractice premium if you're not up to seeing, 40 hours a week of patients. If you're 20 hours a week, you can get 50% off your malpractice. So I think I'm like right now probably around like $150, $120 a month malpractice premium as well. So that is awesome. That's my only expense. So way to go, low overhead, folks. All right, so anything else that you two want to say about prescribing online or iPrescribing or anything?
I use Charm EHR. So I use that to prescribe my medication. And so that one is actually a free EHR unless you are like me, and I like to have my calendar synced to my regular calendar so I know when I have patients, because like Kendra, I have a home office, so I don't pay rent because my office is downstairs in my basement. And so I just sync my EHR up to my calendar so that I actually know when I have an appointment, so I can be upstairs, in the kitchen making some tea, and then I'm like, oh, I have a patient, and then like come back downstairs. So it's just a way to help me manage myself while I'm at home that I have a clinic or I don't have a patient in the clinic. So so that's $25 a month for that process. That's the only reason I'm paying the $25 a month. Otherwise, it would be free for me. So
what
$10 a month to pay
allow
for prescribing.
So this leads to a really nice segue to another question of what platforms allow patients to self-schedule. So
Charm does.
And what about you, Kendra?
Yeah, so I use IntakeQ, which is, again, what I use for our EHR. And, yes, it allows it. If you go to my website, freerangesites.org, you'll see, if you click on make an appointment, you'll see what it looks like. It integrates into my website, like, really, really easily. There are, I think most EHRs these days have something like that. one thing that I just found, I'm kind of like a tech geek myself, so I actually tried out a lot of different EHRs and a lot of different like kind of platforms and scheduling systems before I settled on one. I think like a lot of them offer it, but some of them are a little bit clunkier, and they might not be as pretty or might not be as simple. I like IntakeQ personally just because I feel like it's like the easiest thing in the world and it has a lot of options. But a lot of EHRs, I would say, these days have something built in. Most of them do. Or you can get standalone scheduling stuff as well.
Yeah.
And then another question.
Oh, go ahead. It has like you can sign on to the patient portal, but I actually embedded the calendar into my website, so patients, whether they're new or established, can create a new patient consultation, and then I just send them my Google form that has all of my and the screening questions on it. And I just wanted to I think there's a lot of you that use Google Suite, and if you sign to BAA with them, Google Hangouts and your Drive are HIPAA protected. So just remember that. You don't need to go looking for a whole new fancy platform. You could just use Google Hangouts.
Okay, so next question. I do want to quickly answer this malpractice question that was asked. If I'm working quarter time, like 10 hours a week, should I ask for a discount? Absolutely. Every single person, unless you're kind of approximating 40 hours a week, you should all be on discounted malpractice. Not all malpractice or medical liability insurers will allow you to have this part-time premium, but that's one of the things that I think would be really important as you're scouting out what coverage you want. You want to have one that allows you to you're discounting their risk when you are only seeing, instead of a patient panel and big box assembly line medicine, family medicine, where it's 2,300 patients per doctor, if you're just at home doing telemedicine and have a patient panel of 200 patients and working 10 hours a week, like you should be getting 3/4 off your malpractice premium, which is what I get. And so please remember to ask for that. So the next question is, so about starting out, I know there's a lot of people who are still in residency. They're wondering like how they fit into this. RNs who want to help, during this pandemic. So my question that one person has just asked is what Pamela had mentioned as well, is just how to start in the sense of finding clients and branding. I know it's reaching out to the community somewhat, but I think I found it hard to do that as a resident as well. This is similar even if I was starting the brick and mortar practice. I think this has been discussed before as well, but just curious, if we were to start now in this environment, what would you do if you were starting over? And I'll just answer first, which I think you have to find the ailments, the medical conditions that you're most passionate about, that would invigorate you to see clients with like ADHD or obesity, or usually there's something that we each are very passionate about. And if you can segment down to that target demographic and really reach them, which it's so easy online to find chat rooms full of people that are struggling with obesity or ADHD, or find local, bereavement groups and support groups for all sorts of different things. So you can find these locally, and through Facebook and other online sources, you can really geographically target them, especially with targeted ads to the disease condition and local geographic location. Because I think, in my opinion, these days people really want targeted care that is where they feel like they're special. They're going to the doctor that specializes in chronic fatigue or fibromyalgia or ADHD. This sort of generic one-size-fits-all assembly line medicine isn't so desired these days, right? And so especially if you're in psychiatry now, you should have no trouble being able to reach out to people who are having anxiety and panic attacks during a pandemic. This is a great time to start building your online presence in any sort of psych capacity. I know this question came from a psychiatry resident. So what do you two believe about if you were to start over? And I know, Kendra, you've been open for some time, and Carrie, you just launched, more recently. So any thoughts as to how to reach out?
Yeah, I totally just would 100% second what you're saying, Pamela. Like, it may seem counterintuitive. Like, when I first started out, I didn't listen to that advice, and I was like, I'll take everybody and anybody. I also didn't really know who my ideal patient was, to be honest, but I just kind of did whatever. And you know what? It didn't work very well at all. And then I kind of found my niche, which happens to be like, very specific holistic psychiatry, people who want to get off psychiatric medication specifically. And then once I found that niche, I had just people lined up, around the block, like coming to see me, because I'm that one special person that can do that one special thing. But there's a bazillion patients out there who want that one, specific thing. But once they find out that you're the person who is that, wonderful expert in it, it's like people just come to, they just keep coming and coming. Practically, from a practical point of view, though, I'm currently licensed in 5 different states, and previously was working, seeing patients across 5 different states. So if you think about it, just going, I can't just go around the block and hand out my cards and stuff like that, right? Like, because I'm seeing patients, crazy, in New York and Florida and all these different places. So I actually I tried a couple of different things. Me personally, I found Google ads to be the biggest bang for your buck. Obviously, you have a website, that has all the information out there, and then you type it to a Google ad, which, yes, you can do targeted. You can say which state. So, like, I have my Google ad set up so that only people in the states that I'm offering care to will see my ads. And they help you, figure out what tag words to use and things like that. So from a practical point of view, I found the Google ads to work really well. In fact, they actually worked so well, I had to turn them off because I was just getting so many patients. So, and then once you have that too, by the way, it's just starting out, then word of mouth, I feel like, really carries you. Like, once you have those, first patients in the door, they tell their aunt and their cousin and their whatever, and then I think that's how you kind of continue to build from there.
So
anything else?
Yeah. Oh, I was going to say, anything else, Kendra? Okay.
No, that was it. Yeah.
Okay, so I put a ad up on Facebook, and I have a panel of all 7 patients, and 5 of them came from my Facebook ad. And I paid $30 for my Facebook ad, so I think I got a great return on my investment. So I just actually have an ad that runs for $1 a day on Facebook, and that's the target demographic that I'm going for. It's kind of like my 20 to like 40-something-year-olds that are overweight. So I'm actually took my ad down because I want to revamp it and gear it a little bit more towards obesity a bit more and overweight. And I'm actually also advertising, and I was running a class until all this happened at a local gym, and I'm going to try to transition that to online. If this lasts for another week, I'll probably do it as a free service just to get people in the door to see what I have to offer. And then move forward with that. But the demographic that I'm going for is all going to be online and comfortable with using that medium. And so I completely agree with Kendra. I was actually going to be looking at doing a Google ad once I had a few more patients. And then word of mouth, I went to 2 neighborhood meetings, and my name got circulated through that as well. They asked me to be on a small business association in our local area as well. And I'm actually setting up a medical district booth for our street fair, and there's a local GI doctor and a endocrinologist that are down the street, which I didn't even know exists before I started this, that we're actually going to be doing a combined weight loss thing that we may end up publishing. So look out for that. It would be pretty cool. But so I don't know if that helps. I kind of used the blast approach, but I think my Facebook ads was really the most helpful thing.
So I want to echo what both of them are saying, which is you want to get targeted. For those of you who are sort of a little bit in a nebulous zone, I don't know what diseases I like. I don't know what ages I want to treat. I don't know, as you get going, one way to figure this out, which I have a number of medical students working on this project right now who call me, in despair about what they want to do for their future. I'm like, look, make a list of all the patient encounters you had that brought you the most passion and joy during medical school and residency. And if you can't come up with a list of 10, keep thinking because you want to really try to figure out where it is that you want to put your energy and focus, because if you're all over the place and scattered and you don't know who you want to serve, how are the right people going to come to you? But it is something where you need to take some time of introspection and really think about wow, the patient that I loved seeing this week the most was this one. Well, why is it that one? Is it because you really like, geriatric patients and spending that quality relationship building time with them? Or, just kind of ask yourself that question. And one way that I think some people can try to figure out who they want to serve the most is maybe even starting, this is a question for you both, by the way, is anyone doing group visits with telemed, telehealth, Zoom, or other? Because I think there's a way that medical students and residents could probably be doing some sort of group Zoom-like activities to narrow down who they really want to serve and start focusing in on their target demographic. What do you two think about that?
So yes, I actually have led several group. I actually did official kind of group therapy. I'm saying official because I just wanted to make a point here because I had some ideas recently and I talked about my malpractice carrier and got some things sorted out. Which is that at least as a psychiatrist, if I call it group therapy and I'm actually using my MD/psychiatrist hat, all the standard laws apply, meaning I would have to be licensed in the state where I was seeing somebody. And what's the other thing? There was something else. All of a sudden, I'm having a brain fart. But anyway, basically, all of those rules would kind of apply. But if I were to do something like a support group, which is more of I'm kind of a moderator, facilitator, kind of talking to people, getting people together, doing it that way, and not really doing it as a psychiatrist/doctor. All those rules did not apply. It doesn't go under my malpractice, and I could do it I could open that up to anybody. And the reason that this came up for me is because I had the idea to start a support group I hadn't decided, but maybe healthcare workers or maybe just specifically doctors. I haven't really figured it out yet. And I'm still planning on doing that, but I just haven't figured out some of the details. But the cool thing would be if I'm doing it as a support group, I could literally open it up to anybody over the country. It wouldn't be a big deal. Or if I wanted to do it, specifically as an actual kind of group therapy thing, then I would, specifically technically only do it in those certain states. But it was really fun. I actually used Zoom when I did it. I did it on the topic of mindfulness-based cognitive therapy. We all got together. I used this workbook, and we kind of did the stuff together. Oh, that was the other thing that I meant to say. So if I was doing it and calling it therapy, then all of the people in that group had to be my patients. They all had to, go through the intake process and be somebody that I actually established care with. If I'm calling it group therapy and actually doing quote therapy. If you're doing a support group, my malpractice carrier says that it doesn't, it would not, they don't have to be my established patients. I could just open it up to just, anybody basically, if I was doing it more of a support group, which I think is kind of cool. So basically, yeah, the answer is yes, you can definitely do groups. It just would be kind of important, I guess, to figure out kind of what kind of groups you're thinking about, and then you can figure out who would be appropriate and who you might want to include in it. But it was really successful, and it was a lot of fun.
So anything else you want to share, Carrie? Yeah, I was going to say support group or group visits is a new concept in medicine. I actually set up an entire group around some of my weight loss stuff that I've done in the community, and I have not called myself a medical provider in that. I'm just an advisor with some medical training, and so I haven't needed to worry about exactly what Kendra's talking about, not actually using my medical degree in that scenario other than just being an expert. So they're kind of just getting a lecture, and I don't charge them. But if you were looking, and I think this is really important for medical students now to be looking at, and residents, about when you get into your future practice, pushing group medicine forward is really integral, especially for your chronic diseases like diabetes. I mean, if we look at heart failure, right, that's a big one that we see a lot of benefits for patients. And we're starting to see that more with COPD as well, and having a respiratory group that is similar to heart failure. So it's definitely a very big benefit. You can do it on Zoom. If you were to charge a 99213 or 4, depending on what you were doing with each visit. And there is a way on Zoom to make it anonymous so that people can't see that. And then I would just mention to your patients to cover up the camera, don't log in with your camera so they couldn't see you. Or just you actually doing the visit with a lecture and then you could contact each patient individually afterwards. So that creates a little bit more complexity because on telehealth you're having to do one patient at a time. But it may just be a simple check-in. Did you have any questions? Can I see your food log? That's kind of what I'm looking at. Did you have any epiphanies this week? And sometimes people can talk about that if it's like on a telephone. You can use multiple mediums to connect these together. And I think that the next generation is going to be looking for us to be more flexible.
Awesome. Thank you. And yes, post a disclaimer that you're not providing medical care, and this is not, telemedicine if you're doing a support group style visit. I think clarity is key, and to really, again, focus in on that target demographic that you feel so inspired to serve that you almost can't sleep at night. Obviously for me, it's suicidal doctors and doctors who are struggling with depression, anxiety, and all that. Like when you find the group that you feel so aligned that you want to dedicate your life to this, then you can do this through your practice or running a support group for pre-med students. There's pre-medical students that need so much in the way of mentorship and help with career decisions. There is a place for everyone to serve, I think, and to find their special place. A few last questions. I'm sorry this went over because this is like close to 90 minutes, I think, by the time we're done. But these generic questions, how do I get set up? How do I get people scheduled? Are they self-scheduling? Are they calling you? How to charge or set up the charging before the call? So I think we answered most of that, which is like get really clear on what you want, find your target group, whether it's people who are struggling with obesity, in Washington State, or, psychiatry, people, that health professionals that need psych services, or whatever. And then I think we already answered, some of these EHRs are very integrated and you can, have the scheduling and everything happen in one place. It sort of just depends what you're going to use. And Square is very easy to use as a payment, method. But I think what we'll do is we'll probably just continue a lot of this online, the little sort of details of what people decide that they want to use, and continue on our Voxer chat and other places where we can all chime in for specific questions. But
hey, Tamara, can I mention one little quick thing about payment for insurance, because I think it's a little bit different. I bill once a month, so when my patients sign up for my practice, they go through and fill out all their intake forms, and one of their tasks is to go to my website and actually sign in, and they have an annual membership fee they have to pay. But really the whole point of me doing that is for me to get their credit card on file, so if they don't show up for a visit, they've already signed a contract that states they know that they will be charged if they don't show up, and then I already have their credit card on file for charging their copay at the end of the month as well. And I tell them I charge at the end of the month. I will not notify you, but on the 30th your payment will be processed, or the 29th, or whatever was the last day of the month. So.
Okay, so awesome. For those of you taking insurance, please contact your provider reps, check your insurance contracts, and make sure you're going to get paid for these innovative new, things that you want to start with telemed. For those who are not taking insurance, like the world is your oyster and you can create whatever you want, and it's so exciting. For those of you who don't have your medical degree yet, who have been forwarded somehow through your residency, haven't been able to finish residency, can't stand waiting out a pandemic without finding some place to create a niche for yourself and contribute. I think starting support groups are great, and I would think about starting support groups for either your specialty, for medical students, pre-meds, people that are behind you in the process of becoming physicians or becoming whatever specialty you're pursuing. There is a lot of mentorship that people need right now. They don't have anyone to call. That's why I'm getting slammed with calls all over the country from nurses, nursing students, nurse practitioners, physicians, parents of medical students are calling me freaked out about, worried about their kids and how to deal with this pandemic, and they just got into medical school. So there are a lot of people that would value so much of what we all have to offer. I think it's just getting out of the fear, because many of us, again, in the medical world are so wrapped around fear-based decision-making as the way we progress through life. To free of desperation and fear and actually start thinking about what you desire, what you want to create. You actually can live your dreams in medicine and in nursing and in healthcare. There is nothing that should stop you from living your dreams except yourself. Actually, I think we're the ones that sort of are the biggest obstruction to living our dreams. And so I want to encourage you all, and if Lisa wants to do the song, we can do the song today as we end the call, and we'll continue the dialogue online. So I've muted everyone, and I will unmute Lisa if she would like to do our little song at the end here, and let me find her, and then I would encourage all of you who are listening to this, if you still have questions afterwards, please post on our Facebook page, ask on the Voxer chat, reach out to me or Carrie or Kendra independently. We would love to help you. And just most importantly, the biggest message I have for everyone out there, especially people who don't have a resource like this group, and thank you all for allowing me to share this with the greater physician and nursing community out there who is suffering in isolation. I think most important is please have a team of people. Have people that you're looking after, that are looking after you, because we can't do this in isolation. It's so important. We're social animals to have, people who are in your corner, going to bat for you, helping you through this pandemic, the anxiety, the fear, of the unknown. So my last plea for everyone is please do not isolate. Reach out to me. I'm available 24/7. I don't care. It's totally confidential. You can go through my website. You can tell me anything. I've never, by the way, called 911 or told a medical board about anything about what a physician has shared with me. So everything is confidential. You should feel safe with somebody in this world to share your pain, your suffering, if you are a healthcare worker. And the purpose of this call is to give you some inspiration from doctors who are finding their way, and nurse practitioners and PAs and RNs and others. And so, Lisa, feel free to jump in. I've unmuted you if you're here. Are you here, Lisa? Uh-oh.
Oh, here I am.
Yeah.
Can you hear me?
There you go.
Yeah.
Yes, I can hear you.
Here I am with my chickens.
And then we will wish each other well till Wednesday when we talk again.
So here's the song. Make sure you mute yourself and then sing along in your room or your car or your call room or your garage or your park. Happy doctors who enjoy the lives we lead. Happy doctors who have turned our backs on greed. There's more to life than being pushed and shoved around. We're here to serve our patients and we stand our ground. Happy doctors who love the lives we lead. Good night, everybody.
Good night.
Good night.
Okay, you guys can all say good night. Good night.
Good night. Thank you so much.
Thank you, everyone, for all the great sharing. I'll send out the recording. Bye.